In this video, Nigel Edwards of the Nuffield Trust is going to be joining us to explain how to turn the theory of the Socio-Technical Allocation of Resources into practice by moving money and resources around within an ICS for the best benefit of population health.
The economic theory about the reallocation of funding and the use of payment mechanisms to achieve this has a few problems when it connects with reality. In theory, we should, following methods such as STARS that we've heard about earlier, be able to move money and other resources between different elements of the pathway without too much friction. Unfortunately, this isn't actually the reality, and there are not easy answers for how to overcome this. So negotiation, trust, good relationships, and willingness to take and share risk are probably as important, if not more so, than the technical design of payment systems and budget mechanisms to move money around. However, let's look at those. One major challenge is where we get spending that takes place in one budget, but where the benefits accrue in others, possibly in other organisations. Mechanisms that allow for gain sharing and risk sharing between organisations can help with this, but it takes some negotiation, and for some providers there remains a serious problem with what are sometimes called stranded costs. So, for example, we might want to reduce outpatient visits, both first attendances and follow-ups, or reduce bed days. But in both these cases, the direct costs of care, the marginal costs that are actually saved by shortening length of stay or by not seeing an outpatient, are very small. The cost of a new outpatient appointment is £250. The actual direct cost of that in consultant time, some administrative staff, and the heating and lighting of the outpatient department are probably only a very small proportion of that total the total bill. And the problem for a provider when resources are moved is that the medical, nursing and other staff who are providing that service are also engaged across a range of other activities, and it's not really possible to isolate or monetize savings from their reduced activity. Also, these high volume activities such as outpatients are often used as a way of dumping a large amount of overhead, so they attract overhead, and a significant proportion of their costs include that, which of course by definition also don't vary with small changes in activity. This means that providers are losing income much more quickly than they can shed costs, and they don't have many ways to deal with this. One is to increase income from other sources to cover this stranded capacity, which might not be possible or indeed desirable, depending on what your intentions are, or they need to make sufficiently large changes in activity that allow them to release fixed costs. And this takes time, and so processes to profile savings and investment over time will be needed. It's unlikely to be available as an approach within the single pathway. It's just not going to release enough resources. So it may be necessary to do this at bigger scale and to bundle the savings together. This is the sort of process that was used to close the large psychiatric hospitals in the 80s and 90s, and that was often over a period of some years to allow enough change in activity for the hospitals to be able to release large chunks of fixed costs. There are similar issues where savings turn up in a later time period, and again, multi-year profiling of spending and saving is going to be needed to manage this. So financial frameworks for large-scale change and to move money between different parts of the pathway are an important tool in the box in this situation. And there are other mechanisms as well which we might think about to make more micro-level changes in allocative and technical efficiency. Bundling payments that combine otherwise separate payments to providers into a single amount to cover a pathway or a defined population is a method that's been adopted in a number of health systems around Europe. They can be bundled across providers and services, and the price of the bundle is negotiated, probably using HRG and other local cost information. There's a degree of negotiation in here, and people have been interested in the use of a large contract to do this, but they're quite complex and difficult to use, it appears. The approach has the advantage of effectively handing some of the problems of dealing with stranded cost issues to the providers to sort out, and they are better placed to do this in the system than perhaps the payers are. Similar approaches are taken to shared savings models where savings are compared to the historical benchmark costs that you'd expect to have before the pathway, and then the risks and benefits are shared between payers and providers, and that can be used to incentivize providers to improve or change services. Mechanisms that can also help ensure that you get continued compliance with the revised pathway are sometimes helpful here. So providers can receive additional payments for the task of coordinating care, so-called pay for coordination. or they can be given incentives to produce particular outcomes, pay for performance, although, as we know, in a number of cases, pay for performance contracts are actually as much about compliance with process as they are about producing outcomes. But still, it's a useful tool. There are constraints, however, in some of these payment models in terms of the flexibility of the contracts that we're using. For example, the GP contract, which already has a large number of detailed micro incentives, and many might argue too many, which are already in use. And you may find that there are constraints about the extent to which you can incorporate additional ones into their contract, and also the extent to which they have the capacity to manage large numbers of other additional requirements. So this requires a careful assessment of the local situation to see whether we've got the preconditions for doing some of this, particularly the introduction of complex payment mechanisms. This will include, have you got data on quality and cost that you need? Do the providers have the sufficient capacity to do this? Have they got some financial headroom to allow them to assume some risk? Is there the leadership and supportive governance structure to allow for some of these things and to allow for dealing with disputes and problems where people perhaps don't stick to agreements? And you're also going to need continuous evaluation over the longer term. So we need a process to look at the global resources, the changes required and the impacts on providers, and how to mitigate and manage these. And I think there's probably 5 things to remember here. First of all, understand the cost structures and economics of the participants and how these changes impact on them. Secondly, work to develop trust, shared goals and mutually supportive ways of working. Third, be prepared to think longer term. Fourth, don't overcomplicate it. Fifth, evaluate it and adjust as you go. Thank you very much.